Thanks, Kat. Thanks for inviting me to speak today. I'm just going to share my screen, so bear with me. So, yeah. No, right, okay. Here. So, my presentation is why early triage or screening and time identification matters. So, I'm going to cover why is early triage, or another term for triage is screening, important. We're going to cover lots of case studies, points of opportunity in that clinical pathway, and tips to identify significant medical history for non-specialist midwives. The importance of early triage. So we know those physiological changes. Hang on, I've just got a bar up here that I can't actually see the presentation properly. Derry, is there a way of getting rid of the bar at the top which shows audit? Yeah, thank you. Taking it out, that really helps. So from 6 weeks of pregnancy, the blood volume increases and the cardiac output, the blood pushed out of the heart, increases to 50% above the pre-pregnancy increase by 16 to 20 weeks. So what that tells us is that there's already significant changes in the work that the heart has to do in that first half of the pregnancy, and even from 6 weeks. So any pregnant person with a diseased heart needs to be seen early so that the specialist team can get together and plan plan their enhanced surveillance really early on. So any significant cardiac disease needs early fast track pathway for booking an MDT input. VTE risk, from the onset of pregnancy, so that's from very early on, the blood becomes stickier. You have a hypercoagulable state. So whilst it's at its most sticky in the third trimester, even as soon as you have a positive pregnancy test, the blood is already starting to be sticky. So that VTE risk is already starting that early on. And in the last embrace, 29% of the women who died of a VTE died in the first trimester. Not because it's the highest risk for VTE, that's in the third trimester in the postnatal period, but because of the delay in care. So opportunities were missed when the pregnancy self-referral was received to identify those women at particular risk, and then a delay happened because they were taken through a traditional maternity pathway. And we'll talk more about that, and I've got a case study as well. So any pregnancy self-referral form that you pick up, if you see that it says previous blood clot, previous VTE, previous pulmonary embolus, previous DVT, previous clot anywhere, it's really important to have a discussion with the obstetrician. So pick up the phone and have a chat to the obstetrician and discuss the consideration for the prompt prophylaxis. But of course, you'll need to take a history for the woman to find out where the blood clot was, when it was, what treatment she had, etc., so that you can have that full discussion with the obstetrician. When you pick up the phone and you have the discussion around that history, it's really important to listen out for nausea, vomiting, hyperemesis, immobility, and obesity, because they're the themes that were linked with the women, or some of the women who died in that first trimester. So just giving you some tips to be vigilant, but that's obviously throughout pregnancy and postnatally. Epilepsy, so we know that the SUDEP risk, sudden unexpected death in epilepsy risk, is higher in pregnancy and postnatally than outside of pregnancy. And around a third of women who have active seizures pre-pregnancy can have worsening seizures during pregnancy. Critically, there are lots of concerns by women with epilepsy of taking anti-seizure medication because of the potential harm to their unborn baby. So it's really not unusual to ring up a lady at 5 weeks and for her to say, I've reduced my dose of my topiramate because I'm worried about the effect on the baby, or I've stopped the medication altogether. So don't take a history just around what medication she's prescribed, but ask her about the tablets that she's taking and whether she's changed that dose at all, or what her thoughts are around it, and has she had any discussion preconception around the medications and epilepsy care in pregnancy. Because reducing medications or stopping medications has been linked to epilepsy death, SUDEP. And Embrace highlighted recurrently where there were cases where the maternity unit picked up that the lady had epilepsy, but by the time all the talks had happened with neurology and plans had gone through, it was too late. The lady had already died of SUDEP. So it's about reducing delay at every point. So from the early part, but also from any discussion you're having, from any prescription change, all of that needs to be carefully considered so that there's a reduction in delay. Risk of essential medications being self-stopped or stopped in primary care. So deprescribing, as they call it, has been highlighted in Embrace reports as a risk for maternal mortality and death. So again, take a careful history early around were you on medications before? Have you stopped them? Did your GP give you any advice about it? And if she tells you that she's self-stopped, or the GP has stopped, then stop the medication. It's really important to, if you're not a specialist in this area, to have a discussion with the obstetrician around, was it appropriate that that's stopped? How soon do we need to see her? Do you want to see her earlier? And the opposite is true. So contraindicated medications. So there aren't that many actually in pregnancy, and there's increasing safety data from research around medications in pregnancy. But some medications are still contraindicated. So if there's a medication that you don't recognise is outside of your scope of knowledge, then and you picked up that pregnancy self-referral before booking, if you see there's medications listed, then do pick up the phone to the obstetrician, have a discussion around that medication. And they may say, okay, actually, let's bring her in. I'll see her in the day unit tomorrow, and I'll switch her over from that antihypertensive to the next one. Because if you wait, you've got to wait for the booking and then for the obstetric appointment, and you could be, another 6 weeks on while she's on a contraindicated medication. So lots of opportunity to get in early and make sure that the appropriate history is evident and that she's on the right clinical pathway. And then when you're having those discussions early, obviously nausea and vomiting is so common in pregnancy and can be so disruptive to people's lives in lots of different ways, but particularly around medications. So anyone on medications, it's good to pick up the phone and ask them how they're getting on with them, because that can be proactively managed with antiemetics. So let's not miss that opportunity early on and to help women adhere to those medications. So the traditional, hang on, that's better. The traditional process where you haven't got an early screening or early triage process in place is the pregnancy self-referral forms received. It's picked up by someone who might be an administrator who refers it on to the community midwife based on address, or it might be a midwife that's screening them to route them out to a relevant team. But it's really important to find out who's in that process at that point, and wherever you're working, if you're a part of this process, having some ownership over that pregnancy self-referral form at the point it's received is really important. And then referral to obstetrician, and then obstetric review 12 to 20 weeks. I'm going to put another arrow in here, and that's because you've got two opportunities here for reducing delay. Pregnancy self-referral, early screening, highlight, discuss, take a history, where there are any concerns, have early discussions, don't wait for booking necessarily. After booking, if something's apparent in the booking, then you're going to refer to the obstetrician, but have some ownership over what timing they're seen by, because if you put next available, the administrator may make an appointment for 2 weeks, or it may be 6 weeks, but you need to have an idea of the timing and appropriateness of that timing for that person. So right time, right person. So really important, because you'll see in the case studies, there are cases where the midwife probably presumed that the obstetrician was going to see her earlier. Sorry. The obstetrician was going to see the lady earlier, but she happened to turn up at 18 weeks because of the administration process, or because she DNA'd before. So you really need to have a proactive approach and ownership over that part of the pathway too. So a delay in care can risk maternal morbidity, mortality in pregnancy. So those two opportunities are great for reducing that risk. That any delay is a knock-on delay. For a complex pregnancy, you really need to start early to get your MDT around that woman, that multidisciplinary team, and that takes time to get the renal specialist or the cardiac specialist aware of the history. So if we give the teams an opportunity to start early, that will reduce delay for the woman, reducing that risk. If you're not a maternal medicine specialist midwife, then that lack of knowledge around significant maternal medicine, medical conditions can delay or omit the required input for specialists and for opportunities for the maternal medicine centre to be involved in the care. And if we're not taking full ownership over the ladies that we're looking after and they DNA that obstetric appointment, it may be that they go through half the pregnancy and they still haven't seen an obstetrician. And you thought that the time that you referred for an obstetrician at the booking at, say, 11 weeks, that it's okay, you've ticked the box, it's done, she's going to see the obstetrician. But she may DNA 2 times and may not be seen until beyond 20 weeks. So it's really important that we keep we enhance our vigilance around those ladies with complexity. We might miss subtle clues in our generic history taking as well. So really peel away, ask more involved questions. Of the maternal deaths that happen during pregnancy and post-pregnancy, so in that year postnatally, 107 deaths were attributed to a delay in antenatal care. So that's some of that is attributed to this early screening process. We really need to take extra care around this part of the pregnancy and look and map our processes and work out who is making those decisions. So first case study is around epilepsy. So traditional maternity pathway is undertaken. So pregnancy self-referral, community midwife based on address, and obstetric referral from booking. So the pregnant person with epilepsy is booked and she's reviewed by the obstetrician at 18 weeks. And I'm not entirely sure why it was 18 weeks. But most certainly that's too far on, but that may be admin, it may be a sort of delayed process, or it might indeed be a midwife who's indicated that would be okay to be seen at sort of 16 to 18 weeks. At that appointment, the woman reports new frequent nocturnal seizures since pregnant. She's taking her benzodiazepine, clobazam, every single night, and before pregnancy, she hardly ever took it. And she's not been able to get a response from her neurology provider. Her epilepsy team are from a hospital that is not the same hospital as she's having her pregnancy care. And she's left several messages on the answering machine of the epilepsy nurse, but hasn't managed to get a response. So nocturnal seizures, convulsive seizures are linked with SUDEP, sudden unexpected death in epilepsy, and we've already now got a delay of 18 weeks. She'd been pregnant for 18 weeks and the seizures have been worse for that time, and we know that that's increasing her risk of epilepsy injury, SUDEP, but not just that. She's got enormous disruption in her life. She's working full time. She's not sleeping well. She's frightened. Her husband's concerned. She's trying to reach out for support, but she has not been successful until this point at 18 weeks. So she's seen by the obstetrician at 18 weeks. The plan is from there, the obstetrician's going to contact the epilepsy provider and review the woman back in the clinic at 2 weeks. Unfortunately, the obstetrician only had control of that care themselves and they went on emergency leave. So when the lady arrived 2 weeks later for the obstetric appointment, it was a different obstetrician who wasn't sure whether the previous obstetrician had managed to contact the neurology provider or not, but certainly the woman hadn't heard anything. So then their plan was to contact the epilepsy provider, and this woman was 20 plus weeks by the time she had a change in her medication. So she's gone through half of her pregnancy carrying that additional risk of death or morbidity, which is completely unacceptable. So that early triage system with the midwife could have been sought urgently early at 6 weeks. It's a complete missed opportunity, 3 months wasted in a traditional process. If we'd picked up the phone at 6 weeks to that lady where epilepsy has been cited, we would have had the opportunity to start those conversations early. The second case study is around contraindicated medication. Again, going through a traditional process. The pregnancy self-referral cites that the lady's 5 weeks pregnant, she had assisted conception, and she's an advanced maternal age over 55. She's a known essential hypertension. She's booked by the midwife, and she has an obstetric appointment at 14 weeks, which reveals that she's taking ramipril for her hypertension. Ramipril is contraindicated in pregnancy, but really easy to switch early over to an alternative safe antihypertensive. But instead, what happened was that duty of candor was disclosed because of the delay, and the woman is counselled around the fetal risk and has to undergo increased fetal surveillance, which also included a hospital, a regional hospital screening process, which, as you can imagine, really increased her anxiety around this whole process. She'd spent, almost a decade trying to get pregnant, and then this situation arises. So the early triage system, who picked up the phone at 5 weeks when she'd identified, and she wrote it on there that she was taking those medications, would have identified that she was on a medication that was contraindicated. And then a conversation could have happened with the obstetrician and with the woman around switching on to an alternative. This would have avoided the teratogenic risk to born baby, the anxiety for the mother, and the additional fetal screening. So, third case study, and these are all cases that I've seen in the last 6 months, but just to give you some background, in both trusts where I've encountered these, an early screening process, an early triage system by a specialist has now been introduced, and this scenario would not happen now. But just to carry on going through the case study. So this is a renal case where the lady puts on a pregnancy self-referral that she has chronic kidney disease. She's booked by the community midwife, and she sees the obstetrician at 15 weeks. She's got chronic kidney disease, stage 3. It was an unplanned pregnancy, so she hasn't had any preconception counselling, and so she hasn't had the full discussion around risks of the pregnancy. And her creatinine that was taken by the obstetrician at that appointment at 15 weeks is creatinine is 200, and her PCR is already 280. Anyone with chronic kidney disease has increased risk in the pregnancy for both themselves, their own health, and for the baby. And if we'd got in early, it would have facilitated those discussions between the obstetrician, the woman, and the renal team around the risks and benefits of continuing that pregnancy, and discussions around the long-term impact on the kidneys, potentially, that may have facilitated a different choice for that lady. And of course, a raised PCR in any scenario increases the risk of a VTE. So certainly at different trusts, they have different policies. But for instance, at St George's, thromboprophylaxis has commenced when a PCR is around consistently around 100 or more. But at GSTT, Guy's and St Thomas's, in a recent presentation, it was stated that that's around 300. So they'll start thromboprophylaxis at around 300. But it's not debatable. An increased PCR can increase the risk VTE. So again, increasing that lady's risk. So, but with early screening, early triage, this lady could have had an expedited pathway, brought in early discussions, so that would have facilitated a safer process. So this is a case study around VTE, where the new process has started. Joe and I saw this, called this lady yesterday. Joe's a specialist midwife over at SASH, Surrey and Sussex Health. We worked together there. We were screening the pregnancy self-referrals, and we looked at the referral. The lady's 5 weeks pregnant, has written that she had a previous blood clot. We called her, and she disclosed that she had a pulmonary embolus in 2021. She stayed in hospital for a week following because of the symptoms of the pulmonary embolus. That's quite significant. And she was recommended to go on lifelong anticoagulation, a DOAC called rivaroxaban, because no cause were found of the pulmonary embolus, and so she was an unprovoked VTE. Definitely puts those women in a higher risk category. She stopped it in December last year because she couldn't see the point in it. And actually, with further discussion over the phone, she reported that she was very depressed. She had fibromyalgia, chronic pain, and PTSD from that pulmonary embolus episode, which she'd never really recovered from. And she spent most of the time in bed. In fact, she spent so much time in bed that she now got a pressure sore. And she was seeing the GP that day, yesterday, and being treated for an infection of that pressure sore. She's 29. She's got normal BMI, but her life is completely modified by her health and mental health. And of course, the immobility increases the risk of VTE, in addition to the unprovoked VTE history and the fact that she stopped anticoagulation. So there's lots of red flags going on in this situation. So Joe and I had a long discussion around the risks of VTE in pregnancy and in her individual circumstances, and we really explored her medication resistance and why she stopped her medication in December. Because initially she said, "I'm not having anything in pregnancy. I'm not having any anticoagulation. I don't care. It's no point." So we had a really long discussion around it, and she agreed to come today. So she's seeing Dr. Dillahunt this morning. And we've had a full discussion as an MDT. She'll be started on low-rate molecular heparin as an intermediate dose. So all of that is happening at 5 weeks pregnant, and that is an example of how that early screening can increase safety for women with medical conditions. So just some tips. If you're a non-specialist, then it's when you're taking a history, when you pick up the phone, you have a chat to the lady, and she says, "Oh, yeah, well, I'm under a neurology team at, say, East Surrey or Guy's and St Thomas's, or I go to the Brompton because I've got a lung disease." That's giving you a clue that that woman has a more severe condition. So if her asthma is managed by the GP, and it's always been managed by the GP, then that's going to be a fairly straightforward process, likely, if she hasn't had previous hospital admissions. However, if her asthma is managed by a respiratory team in a hospital, then that gives you an indication that secondary care is involved in her medical condition, which is an indication of a more severe condition. So it's really important to ask those sort of questions. Ask around, have you ever had any hospital admissions, A&E contact, because if your condition, that will reveal more information, that will give you more information as to whether this is significant or not. Has she got a current relapse of the condition? Is she having symptoms, active symptoms? And then ask around, have you spoken to a doctor around your health condition and pregnancy? And it may be that they lost a follow-up, that they didn't attend their neurology appointment a year ago, so now they were transferred back to the GP, and they've been discharged from the neurology team because they DNA'd. So they haven't had any preconception counselling. These are giving you clues that you need to get that woman in earlier. She needs to be in front of an obstetrician, or you need to have those discussions with the obstetrician early to decide whether she needs an expedited pathway. Ask about the medications. Has she stopped them? Are they contraindicated in pregnancy? Pick up the phone, have those discussions with both the woman and with the obstetrician. The bumps UCTIS, UKTIS website. It's very good to give you information about medications in pregnancy. And then have a look at the maternal medicine categories, A, Bs, and Cs. A's being fairly straightforward medical condition that can be cared for locally, not fairly straightforward. They can be fairly complex. We've got the right teams in place that can be managed locally, or a B where they need care shared with a maternal medicine centre, or C where it's full care in the maternal medicine centre. There's quite a useful list, which is a good decision-making tool that you can have in your team, where you think, oh, okay, it says that she's got mitral valve prolapse. Is that an A, B, or C? And that'll give you an indication, give you some understanding around terminology that's used and which category that person fits in. And hopefully that will be presented later. But if not, we'll ask Emily if she can send it out to all of the delegates attending today. So that finishes my presentation. Many thanks for listening, and I can answer any questions.
Perfect. Thank you, Trudy. We didn't actually get any questions through during your presentation, so I'd like to encourage people to send some through. Just there's no such thing as a stupid question. Don't worry, anything that you're thinking of, I guarantee you at least 10 other people are thinking. So if anything pops into your head, there's no such thing as a stupid question, please ask. But in the meantime, there were a couple of things that I was thinking of while you were talking. One of them was when you were talking about epilepsy referrals. One of the things that we get through a lot at our trust is women who had epilepsy in childhood but haven't had seizures for 10 plus years and have been discharged by neurology. And how do we, what's the most effective way of triaging them?
I think it's important to take a history. So pick up the phone and have a discussion. It's important to, if she says she had epilepsy in childhood, had she seen a neurologist who's actually said that she no longer has epilepsy? And did they stop the medications? Was she instructed by the neurology team to stop the medication? Or did she just think, I haven't had a seizure for years, and I just stopped the medication myself? And it may be that she's 19 and she's only 3 years out of the paediatric sort of child team. So do clarify the history, but seizure-free for 10 years, 5 years off anti-seizure medication puts that woman into a lower risk category. But it's always important to make an obstetric appointment anyway, so that there could be additional history taking around that case. Would you agree with that, Kat? Is that's what
Yeah, I
you
think
would
that's generally
recommend?
what we do at St George's. Anybody, they have a one-off appointment with our maternal medicine consultants, and they generally kind of safety net them and take a full history, and then they go back to their routine care. Oh, there's some questions coming up now. Somebody's asking if we could just say again the tool that you look at for the medications that are contraindicated in pregnancy.
So UKTIS, UCTIS, bumps, BUMPS, medicines in pregnancy. There's a search bar, you put the medicine in, it gives information about that medication, but it also gives you information that is easily communicated. So in a language that's easily communicated and understood for women. And it's information that you can also, if you've got digital maternity notes, or you can print it off for the woman so that she can read it herself, or you can signpost her to that website.
Good. And then something similar, somebody else is asking whereabouts we find the maternal medicine categories again.
Yeah. And Emily, would you be able to send that out, do you think?
Yeah, I can do that.
Yeah. It's not been designed as a tool for this purpose. However, having implemented the early screening process in a couple of places for people who aren't necessarily specialists, it really, and I use it a lot anyway, because it really helps me. It is a useful aid to work out, particularly around things like renal and cardiac, where someone will use terminology around what's found on their echo. And so you can have a look and compare that to what it's saying in each of that A, B, and C category. And that will help strengthen your discussion with the obstetrician too. So you can say in the maternal medicine category, that sits in a B, which gives us the indication that's more severe disease. And so that can facilitate the understanding around the significance.
And Carolyn's just letting me know, apparently it's on the NHS England website. So, and then somebody else is asking about PCR results. Oh no, it's a comment. Oh no, sorry. I was glancing at it and not reading it properly. It says, I didn't know raised PCR results were a VTE risk. What is the reason for this?
Yeah. Now, Sian, we've got an obstetrician here. Correct me if I'm wrong, Sian. As your blood vessels and your filtration rate in your kidneys changes to let those larger molecules through, you also lose some of your anticoagulation factors. There's a different physiology around preeclampsia, but similar, there's some overlap. But that's the basic premise behind a raised PCR and increased risk of VTE. Would you agree with that, Sian? Is there anything that you would add to that?
No, I talk about it a little bit. I go through different bits of physiology, so we'll
oh, brilliant,
we'll talk about
fantastic.
it with a nice infographic.
Oh, perfect.
Brilliant.
Great. That's the end of the questions. The other thing that I was thinking that we see a lot of that can confuse, well, actually not a lot of, but we've had a case recently where a woman who had a congenital heart disease and was under BARTs, where she didn't declare it on her self-referral, and then when she went for her routine booking, she said, oh, I have this issue, it's all sorted, I've had the surgery, my cardiologist at BARTS has discharged me and said that I don't need any specialist input, I don't want to be referred to anyone. So the booking midwife referred her to us anyway, but she said she doesn't want you to contact her. So I did contact her, and basically what it boiled down to was that, you know, she didn't want to be treated differently. She was I think at school she'd been quite conscious of being made to feel different because of her condition, and she just didn't want to be made to feel different. So we had a good talk about it. But actually, when we got her notes from BARTS, what the cardiologist had said was there were no restrictions on her getting pregnant, but not that she didn't need specialist input, and not that, you know, she didn't need follow-up. And so I don't know whether she had just genuinely misunderstood what they'd said or whether she was interpreting it in a way that she wanted to. But I think we need to be careful that sometimes women do genuinely misunderstood what they've been told by their specialists, and they will tell you, oh yeah, my cardiologist, my neurologist, my hematologist says that you don't need to worry about this. But it is important, you know, just to double check. It's really, really important that their specialist is not at the trust you're working at, that you get the notes, at least even if it's only one clinic letter. Generally one clinic letter will have the details, the medications, the history listed on it. Even one clinic letter can tell you so much and open your eyes to the condition. I don't know what you think about that, Trudy.
Completely agree. And that takes time, doesn't it? Trying to get those clinic
Yeah.
letters. Emily knows this very well because it's really difficult depending on where you're trying to get them from. So yeah, starting that process early is really important.
Yeah. And having those clinic letters available for when they do see the obstetrician as well.
Yeah. And uploading it to the shared system like Cerner so that it's readily available. Yeah.